questions on it?
Dr. Ryan,
What?
is it okay to add a fifth person to our group?
Do you have Addisons?
No.
I don't care. I could be right.
Well, she doesn't have any.
That's right up there with the color of Sally bowls.
Oh, that.
It doesn't matter to me. Doesn't matter to me. All right. Yes, that's how insignificant it is.
Next week is our last class. The week after that is our final.
Do we want to know when the final is?
Yes.
Okay, great.
He's like, remember this in the future.
Oh, that's right, on that one side.
Yeah, and he's like, go there and do this. Don't ask what it
Stark State one, I think? I don't know. He was going to tell us anyway. I'm an retard. Leave me alone.
I feel better seeing it.
Yeah, sorry.
All right, gang. Exam final. Siete de Mayo, 2 days after the Cinco.
And Star Wars,
At
3 days after
noon.
Star Wars Day.
That's my anniversary.
Well, here, I'm giving you a present.
For the fourth grade.
And this is a much better test than the one you got to pee on. A lot less consequences. Okay, siete, whatever it is. Nuno.
Is that your schedule the whole week? Like May 5th, 11 to 12:50 is
Still college.
an anatomy one? I mean, I see we're highlighted for May 7th, but
It's like a card that says if you have class at this time, this is what.
This is the college final exam schedule. This isn't mine. For you people that have been here forever, but it's the first time you're looking at this.
are you too?
All right, so we meet Tuesday, Thursday. For you calendar challenged individuals. And we meet between noon and 12:50, so you bring these together and there. But this works for any class you have. And notice it's noon, not 12:30, because there's no labs that week, so everything is in a 2-hour block. All right? So whatever classes you have, this will tell you when you need to be. And it's this room, it'll be this room. Okay? All right. Anything else on this? I'm going to close it out. All right. What we want to do today is begin taking a look at some of the details that's associated with the respiratory system. In lab, we introduced certain aspects to it, which I'll re-go over today. But what we concentrated on in lab was primarily the mechanics and the anatomy associated with breathing. Okay, that's more of an anatomy-based thing, so that's why we did that in lab. We're going to be concentrating on the majority of the chapter, which is to a large degree taking a look at the biochemistry, or the chemistry aspect that's involved with the system. Now, just to kind of review a little bit, in order to make ATP, we have to take glucose and oxygen, react them, and that will give us carbon dioxide, water, and ATP. We call that formula, that chemical reaction, that is called cellular respiration. And as I pointed out in lab, the respiratory system is involved on both sides of that reaction. It's involved on the acquisition of reactants side because it acquires oxygen. And it's on the waste removal side, so the byproduct side, because it helps get rid of carbon dioxide and to a lesser extent water. So the primary function of the respiratory system with regard to that process is gas exchange. Getting oxygen in and getting carbon dioxide out. Now, the respiratory system has other functions as well, and they're all kind of stemmed or come from that exchange process, so we'll go over those, but that's the main thing. That's first and foremost at the top of the function list for the respiratory system. As you will see, because we exhale carbon dioxide, the respiratory system is also directly involved with acid-base balance. So it's helping to keep pH balance within the body fluid. By controlling carbon dioxide levels, and that'll be part of the biochemistry, is looking at carbon dioxide, you will see we convert to an acid. So if we retain carbon dioxide, then we can become acidic. So the normal exhalation of carbon dioxide helps to minimize carbon dioxide buildup, thus it minimizes acid accumulation, so respiratory system is involved with pH balance. You might not think of that, but it is. In addition, any acid that gets into our body, since the respiratory system has direct access to the outside world, we can get rid of that acid as well, provided that it is what we call a volatile gas, a volatile acid. A volatile acid is an acid that can go basically from a liquid to a gas very easily. NEM! Well, whatever it is, I hope it lands like out in the hole. Are they moving something? All right. Happy win. Another function of the respiratory system, in addition to the pH balance and the gas exchange, voice, helps create voice. But everything that it is coming from is basically stemming from, or coming from that primary function, which is gas exchange. All right, anatomically, just to review this a little bit, basically what we have is a series of ducts and tubes that allow the gas, which is the primary material that the respiratory system is dealing with, which will allow the gas to get to where it has to be. So very simply, you'll see here, we're showing some general anatomy. We start off with the entrance into the respiratory system. There we have the nasal cavity and the oral cavity, but we'll concentrate on the nasal cavity. When we take a look at the nasal cavity, that's the initial part of our anatomy, so we'll magnify that. This is what we see. In order to facilitate the gas exchange and getting the oxygen and gas pressures to be optimized and everything, the first thing we have to do is start to manipulate the air. And that's where the nasal cavity comes into play. The nasal cavity, although it's a cavity, its architecture is designed to do three things. Thing number one is that it will heat the air. Thing number two is that it will humidify the air. And thing number three is it will clean the air. Anatomically, we have a space, okay? And when you take a look at the wall of that space, the lateral wall, you're going to see that we have these bumps of bone in here. These bumps are called turbinates. The turbinates. And what these turbinates do, they're almost these shelves of bone. So if you were looking into the nasal cavity from the front of the skull, this would be our septum, you would see the turbinates extend inward like this. So this would be the air would be going in this way. Here's your nasal septum, dividing up into left and right. These would be the turbinates here. They're also called the conch, so you have the superior, middle, and the inferior, and all the ethmoid bones and stuff like that. As the air goes in, it's going to get funneled through these little spaces or channels that are in there. Okay? The other thing that is going to happen as the air is inhaled, it's going to hit these turbinates, these bumps, and here's where they call turbinates. It's going to cause the air to spin, which creates turbulence. So if you're in a plane and someone says we're hitting turbulence, that air is spinning. And that's why it's throwing everything around. But we want that. As the air hits, it's inhaled, and hits the turbinates, it begins to spin. Spinning means that it's not going forward. It's staying in one area. So that means the air with the turbinates stays in that nasal cavity for a longer period of time than if they were not there. As a result of staying in the cavity, the epithelium, the nasal epithelium in here has a lot of vascular componentry to it, so it means there's a lot of heat, so we're heating the air. That's good because we have to get a gas, which is room temperature, let's say 70 degrees, we have to get it up to body temperature, which is about 100 degrees. So you're looking at almost a 50% increase in temperature. That's going to cause the gas to expand. Gases expand when they're heated. That's good for us because it helps to keep the lungs open. So heating the air is important. So when you're on a ventilator, that machine has to heat that air. The other thing it has to do while it's in the nasal cavity is it's got to pick up moisture. It's got to be humidified. By the time the air gets down into the lungs, it is completely saturated with moisture. It's like the tropics. That prevents the internal lining of the lungs, the internal part of the alveoli, from drying out. You don't want them to dry out because when they dry out, they collapse. And collapsing affects ventilation. It affects gas exchange. As the air is moving and it's going in that circular pattern, as you can attest to if you were on a plane that did this, that circular pattern is going to be like a centrifuge. It's going to cause solid particles to leave the air. The nasal epithelium also has a fair amount of mucus glands. We saw that back in AP1 when we were looking at pseudostratified ciliated columnar epithelium. Don't worry, you don't have to know that. But you'll get it just as right now as you did last semester. So those mucus glands will coat the cavity with mucus, which is obviously a sticky material, and that will cause the solid material in the air to stick. So we've reduced the amount of solid particles that are getting down into the lung. So we've heated it for expansion, moistened it so the lungs don't dry out and collapse, and we've cleaned it. That's the function of the nasal cavity. So it seems insignificant, but that's what it's there for. And also it adds resonance so you can have a particular sound to your voice. Stuff it with mucus, like when you have a cold and you'll hear your voice change. It's not as deep and it's not as loud, it's more nasal. All right, so from the nasal cavity, we now go into the pharynx, which is basically the throat, and this is an area that can potentially be problematic, and that is because both the digestive system and the respiratory system overlap here. They both utilize this tunnel. At the base of the throat, the digestive and the respiratory system diverge, they separate. So going anteriorly, that's the respiratory tract. Going posteriorly from the throat, that's the esophagus, and that's digestive tract. That winds up being an issue due to the fact that at this juncture here, okay, the density of materials that each system deals with is different. For the most part, digestive tract is dealing with solids and liquids. Respiratory system is dealing with gases. If you get gases to go down the esophagus into the stomach, not a big deal. But if you get solids and liquids to go into the air passageway here, the larynx and the trachea, that's not good because now the density of material can lodge. And then you potentially could stop ventilation or stop gas exchange and you'll die. That's stopping pulmonary ventilation, yeah.
Is that how the aspiration has to go?
Right.
It is close, wow.
Oh, yeah. So we have to have a protective mechanism here, which actually starts in the throat. The throat is actually made up of muscles. I don't know if I have them on here. I don't think I have them on this set. They're muscles that actually go around. They're called constrictors. So you have a superior, middle, and inferior constrictor. And they contract. They're skeletal muscle, but they're controlled by the brainstem. And they contract and relax in a particular sequence. What their job to do is, their sequence of contracture helps to guide the food to the esophagus. So there's an area in the brain that's already trying to make sure that the solid material does not go down into the air passageway and block airflow. Okay? In addition to the constrictors, and those are the things that can cause edema, like if you have anaphylaxis, the laryngeal edema, pharyngeal edema, those constrictors, there's muscle, those swell, and that can close off the air passageway here. In addition to that, we take a look at the larynx. The larynx is the voice box that's seated on top of the trachea. As part of the construction of the larynx, we have this component of the larynx. This is called the epiglottis. The epiglottis is a flap, if you will, made up of elastic cartilage. What the epiglottis does, when you swallow, you go through the chewing phase, and now you have to swallow. Swallowing is called deglutition. So when you hit the deglutition phase, you swallow, your muscles in the throat are going to pull your larynx up, so your Adam's apple goes up, which causes this to slap down. What the epiglottis does, as its name kind of suggests, it goes over the glottis. The glottis is the opening to the trachea. That's the opening. It's called the glottis. So what happens is the epiglottis will cover over the glottis. It covers over the opening into the trachea. So if food hits that, the food will actually just run down the surface of the epiglottis, which now will direct it into the esophagus. So not only do we have throat muscles trying to move the food to the correct direction, we also have a mechanical cover that covers over the trachea, the glottis portion of the trachea during swallowing, so solids and liquids do not go down into that. So, and again, this is because of the fact that the digestive and the respiratory system overlap with the throat. And then they have to part ways. So this is how we control that. Okay? Now, once we get through the larynx here, then we are down into the trachea. Here we're taking a look at a sagittal view. They've taken out the larynx and cut it long way. So you're looking, this is what you would see on the inside. The larynx, that's your vocal cords there. So as we exhale, air comes up, hits the cords, and gets them to move so we can generate sound. And then here you can see the epiglottis. When you get into the trachea, you'll notice that the anatomy of the trachea is such that it has these rings. These are called the tracheal rings. And they're cartilage. And these were the hyaline cartilage that you were looking at, if you remember back that far, in A&P1 when you were looking at hyaline cartilage. They were the tracheal rings. And here it is. The rings are described as being C-shaped. So they don't all go all the way around. They are open in the back where the esophagus is, and that opening in between the points of the if this is a ring, it's closed in the back here by a flexible membrane. And then behind that here, you have the esophagus. So when food gets into the esophagus, it has to expand, so this flexible membrane will allow the esophagus to expand a little bit into the trachea. It's not going to disrupt airflow very, very significantly, and yet it still allows the food to get down into the stomach. So that's why the rings are not completely circular. Something would affect that. But nonetheless, the other function of the rings, besides allowing the esophagus to expand, is keeps the airway open. Keeping the airway open, keeping the trachea open, allows us to inhale. Exhalation wouldn't be much of a problem. You have no trouble getting the air out of a balloon. You have to work to get it in. And that would be the same thing here. So the tracheal rings keep the trachea open and prevent it from collapsing. If they fracture, well then it'll collapse and you're kind of screwed. Now, as you follow the trachea down, you'll see that it will begin to divide. From the trachea, we divide into two branches. Those are called your bronchi, the left and right bronchus. And each one feeds the lung, a particular lung. The first branches here, these are called your primary bronchi. The second branches, those are called your secondary bronchi. And then you have your tertiary bronchi. Basically what we are doing is through this branching, even though the branches get smaller and smaller and smaller, they get more and more numerous. What we are going to do, and this is to enhance gas exchange, what we are doing by doing this branching, extensive branching, and getting smaller and smaller and smaller, we are increasing surface area. The greater the surface area, the more efficient the gas exchange. The greater the surface area, the more efficient the gas exchange. So ultimately, that's our goal here, to get a high surface area. All right, now, you'll notice that the bronchi, they look fairly similar in architecture to the trachea. They still have rings and everything to them. Eventually, we're going to have to lose the rings because the rings would just make things too thick for gas exchange. So eventually, we're going to get down to these microscopic branches, which now are called bronchioles, much like we had arteries going to arterioles. Eventually, the bronchioles will lose the cartilaginous rings. By losing the rings, it now facilitates or just makes it easier for gas exchange. Okay? So you'll see that we have, when we get down into bronchioles, we have one group, these are called terminal bronchioles. Those are fairly thick, and they have smooth muscle and some rings to them. And then all of a sudden, there's no more smooth muscle, no more rings. Those are called respiratory bronchioles.
What did you say the ones, no rings?
Respiratory. Because now a little bit of gas, those are so thin, gas is starting to exchange through them. Not enough to keep you alive, but gas is exchanging through them. And then off of the respiratory bronchioles, this is where we start getting the cluster of structures, and here's where we start seeing alveoli. As I mentioned in lab, alveoli and alveolus is the basic functional unit of the lung. This is an area, the alveoli, this is an area where two chief processes need to take place. And I've listed them for you in lab. I'll reintroduce them here. The alveoli are involved in two gas exchange processes. Gas exchange process number one is called pulmonary ventilation. What was the definition of that? I hear the wind. What was the definition of pulmonary ventilation? Got a whole lab on it. Dr. Ryan, we had the blood and immune system injected. Just let us get caught up. What's the definition? Gas exchange between atmosphere and alveoli. Gas exchange between atmosphere and alveoli. So when we inhale, we have to get the inhaled air down into the alveoli, and when we exhale, the air that's in the alveoli gets forced out. So that's pulmonary ventilation, affectionately called breathing. The second process that takes place here is external respiration. What was that? Gas exchange between the alveoli and the blood. So what structure do they both have in common? Alveoli. Yeah, if these are damaged, you're pretty much on the short end of the stick. You're screwed. That's why they are the functional unit. Okay? So when someone says lung, in essence, they're referring to alveoli. Okay? When you're born, you're a little punk, not doing a whole lot, not walking around. All your job is to do is grow. And you don't even do that very freaking well. And you're very loud about it. Boy, you just don't go home. Spend the night elsewhere. Hear that? Like you. That's why you're born with about 6 million of those suckers, those alveoli. By the time you're like 10, maybe even earlier, you now have about 300 million. So it's about 150 million per one. And if I were to take every one of these alveoli, cut it open and lay it flat, made like a quilt, you would have a membrane that is 25 feet by 25 feet. So it would be bigger than this room. It'd be bigger than the rug in this room. And that's how much surface area is all wrapped up, folded up, and stored inside your chest cavity. So that's what many disorders affect. They damage the alveoli. That's what emphysema does. It causes the alveoli to collapse. So it decreases the surface area. So that means I have less gas exchange taking place within a certain period of time. Okay? Now, on the outer surface of the alveoli, since the alveoli are the area where pulmonary ventilation and external respiration are connected, on the outer surface of the alveoli, that's where you're going to find the vascular network for external respiration to take place. So it's much like taking a fishnet, okay, and putting a basketball or something in that fishnet, and that's the pattern that the blood vessels, capillaries, would have on the outer part of that alveoli. So there's a fairly intricate architecture to the alveoli, not only because of what it needs to do for ventilation, but because of its architecture with the bloodstream. So just to review that a little bit, when we take a look at the cells that are found within the alveoli, we have a couple of different types. One of them are type 1 alveolar cells. These are very, very, very thin in their anatomy and size, so it makes gas exchange, diffusion, take place relatively easily. Another type is, these are called septal cells, or type 2 alveolar. These are important because they produce a chemical that coats the inner surface of the alveoli and prevents them from collapsing, and that chemical is called surfactant. By producing surfactant decreases what we call surface tension. Surface tension is just that. Surface tension are forces. Surface tension are forces that take place on the surface of something. And generally what those forces try and do is collapse whatever they're on. So due to the fact that we have water buildup and air pressure and everything in here, that is going to attempt to cause the alveoli to collapse. Collapsed alveoli do not exchange gas very well. So we secrete a chemical that coats the inner surface of the alveoli, which decreases the intensity of these collapsing forces. We call the collapsing forces surface tension. So in essence, what this surfactant, this surface acting agent does is that it decreases surface tension, which decreases the probability of the lungs and the alveoli collapsing. This is why you have to put those things that come out way too early. What are they? Oh, they're not babies. What are they called? Now they're a liability. Yeah, those things. Those premature organisms, they are now out so freaking early, their lungs have not produced surfactant. So their lungs aren't open, and even if they were, they would collapse. So that's why they have to be on ventilators in those little bins they put them in with the holes on the side. So you can pet them like a puppy down there where Pets R Us. They got the tape there. They got that little gum thing sticking down in the front because they don't have the choppers yet. All right. Well, that's what they're called, choppers. Now, if you don't produce that, the lungs will potentially collapse. So what would affect surfactant production would be things like general anesthetics. That's why after a long general surgery where you were on a ventilator, they have to give you breathing exercises because some of the anesthetics poison some of those type 2 alveolar cell, and they decrease surfactant production. So they have to give you breathing exercises to help keep the lungs and stuff open. Also, in addition down here, you can see this, we also have, these are called dust cells. These are their other name is alveolar macrophages. And these are constantly traveling through the spaces down here, removing any solid particles that have gotten through the cleansing system at the top of the respiratory tract. Everything down here is designed to make sure that that gas exchange, pulmonary ventilation, gas exchange, external respiration, gas exchange, we want that to basically go unimpeded. We don't want anything to interfere with it. So everything down here is designed to keep that alveoli clean and open so we can get gas exchange. Because at the end of all this gas exchange are 3 letters that we need. A, T, P. Okay? All right. Now, where the blood vessel and the alveoli meet, and you can see my picture's trying to highlight it here. Where the blood vessel and the alveoli meet, that's an important area. Where the blood vessel meets or is connected on the outer surface of the alveoli, that is called the respiratory membrane. So the respiratory membrane is a combination of the alveolar cells and the wall of the capillary. So the anatomy of this membrane is designed to allow gas exchange between the alveoli and the blood to occur unaffected. So basically, the respiratory membrane enhances external respiration. When you take a look at the architecture of this membrane, the key feature of it is that it is very, very, very thin. Even though it's 2 membranes stuck together like 2 pieces of paper, it's still very thin. That thin nature allows the oxygen and the carbon dioxide to diffuse at a particular rate of speed. By allowing them to go through this membrane at a particular rate of speed, that means we get oxygen into our blood. We can get a certain volume into a certain volume of blood at a particular rate of speed. And that means we can get rid of a certain volume of carbon dioxide at a particular rate of speed. Speed, timing, and everything becomes important because when we take a look at metabolism, we always express metabolism not as being a noun, but as a process, an ongoing process. So that means it has to occur at a certain rate. So we call that a metabolic rate. So in order to sustain a metabolic rate, I have to have the acquisition of oxygen and its delivery take place at a certain rate of speed. And I have to have the removal of carbon dioxide occur at a certain rate of speed. Anything that changes the thickness of that respiratory membrane is going to slow everything down. The thicker it gets, the more difficult it is for the gas to get through it. So anything that causes scarring and fibrosis in the lung is going to slow down. It's going to slow down external respiration. So what would cause that? This is where things like pneumoconiosis or pneumosilicosis, things like black lung, coal miner's lung, all of that scarring that occurs from all that particulate material, the dust, it's going to cause scarring and inflammation, and it's going to cause all of these membranes to thicken. So they might get the oxygen in, but the amount of oxygen that goes from the alveoli into the blood is going to be very little because it takes a long time for it to get through. Pneumonia over a period of time. Every time you have pneumonia, you create scar tissue. And as a result of that scar tissue, it's going to become more and more difficult to have gas exchange. You can get air into the lung, but external respiration is going to become difficult to accomplish. And then that means that's less oxygen entering the blood and less CO2 leaving the blood. So now you're starting to become acidic. So that respiratory membrane is absolutely crucial for external respiration. All right, we will now assume that external respiration has taken place. And again, external respiration is gas exchange between the alveoli and the blood. So that's what my picture is trying to show you. Now, the external respiratory process is basically enhanced diffusion. That's all it is. We have absolutely no physical means to get the oxygen to go from the alveoli into the blood, or to get the carbon dioxide to leave the blood and go into the alveoli. There's no transport, there's nothing. They have to move on their own. Yeah, but Dr. Ryan, in the blood chapters, you talked about the hemoglobins. That's transport through the blood. That's not transport, that's not going through an alveoli into the blood, that's getting into the red blood cell and being carried through the body. We have to completely, 100% rely on diffusion. The best we could do is make the environment such that the diffusion occurs at a normal rate and uninterrupted. Now, what is driving diffusion? Who remembers what diffusion is?
High low.
High to low what?
Pressure gradient.
Pressure, that would have been, pressure, that was filtration.
Water, fluid, with
That's
gases.
osmosis.
Well, it's anything a lot of, and it's gonna go.
I need words. I'm a guy, you have to explain it to me. I'm a moron. It goes high to low, right? So that means if we're in Denver, we should breathe real easy. And then when we go to low, is that the case? Chapter 3. It's doing it. Diffusion is when you go from high concentration to low concentration. And I don't want to hear, well, you knew what I meant. No, I don't know. I can't assume. I can't do that. I'm a guy. Can't assume that. You know what I meant. Now, what enhances diffusion is to keep this high number as high as possible and to keep this low number as low as possible. Okay? The steeper the gradient, the faster the oxygen is going to move. It's like a hill. The steeper the hill, if I have an incline like that, and I have an incline like that, and I have a ball on each of the inclines, which one's going to travel faster? The one with the steeper incline, because the high point is significantly higher than the low point. Does that make sense? So in order for us to get enough oxygen into the blood through diffusion, because we can't push it in, all we can do is create a scenario where we can enhance it. We have to keep the high as possible and the low as possible. And what determines how much oxygen, and this is where the pressure comes in, is pressure. So we have to keep a high pressure because pressure, the higher the pressure that a gas gives, generally it's because there's either compression taking place or there's more molecules there. In this case, it's molecules. So higher pressure of a gas means more molecules. Higher pressure of oxygen means more oxygen molecules. If I lean against the wall here, I'm putting pressure. But if I had 100 other people doing the same thing I'm doing, would the pressure on that wall increase? Yeah, so what that's saying is there's more molecules, more people putting pressure on it. Does that make sense? So the more pressure in this scenario, the more oxygen molecules. More oxygen molecules, higher concentration. Gases, you can, but usually gases, they're always measured in pressures, not concentrations. You can do it in concentrations, it's just that the concentration will change depending on what atmosphere and stuff you're in. Liquids a little bit different. Liquids are a little bit different because you're mixing two things together and they're kind of suspended. Gases, not quite as good. All right. So what's driving the diffusion here is what we call the pressure gradient. What explains the pressure gradient is a law of gases called Dalton's law of partial pressure. That's not Boyle's law. Boyle's law was different. Dalton's law of partial pressure is basically a law that he figured out that helps explain when you mix gases together and they begin to move. Do we have a mixture? Yes, our mixture is oxygen and carbon dioxide. What Dalton figured out was if you have a mixture of gases, the gases behave like the other gases in the mixture aren't there. What that's saying is those gases don't chemically react. And that's a good thing, because I don't want the oxygen chemically reacting with the carbon dioxide, because in that we have no exchange. We would create a chemical that now our body has to deal with. So the gases behave independently of one another. And the fact that they behave independently allows them to travel along their pressure gradient unaffected. So when we measure this, when we measure the pressure of oxygen inside the alveoli, we have a pressure of 105 units, whatever the units are. When we measure the pressure of oxygen in the blood going to the lung from the right side of the heart, so deoxygenated blood, when we measure that, we see that the amount of oxygen or the pressure of oxygen in the deoxygenated blood is 40 units of pressure. So here in the alveoli, we have a high pressure. And here in the blood, we have a low pressure. So if we go back to what I showed here, diffusion for gases is going from a high pressure to a low pressure. Does everybody see that? So that means oxygen will go from the alveoli into the blood. By itself. And it will do so at a certain rate of speed because the pressures are fairly far apart from one another. I got something over 100 and something at 40. That's a far span. Now, if you go to, and this is at sea level, by the way. If you go to a high altitude, let's say you go to Denver, the 40 in the blood doesn't change. The 40 in the blood does not change. But instead of 100 units, let's say now you're down to 85. You're still high, and the blood would still be lower, but notice 85 is closer to 40. So instead of the hill being like this, 105 and 40, it is now like this. It's not as steep, so the oxygen is going to move slower. So when you go to a high altitude area, the higher the elevation, the lower the pressure, the less oxygen molecules that are in the air. Thus, we'll get oxygen into the blood, but it's going to take a lot longer. So that's why when you go to an elevated area, are you active the first day or anything? No, you have to acclimate to it. You have to get used to it. The body will adjust. This is why, and there's no way we can enhance other than just by giving you more oxygen to get the oxygen into the blood faster. So when you go to an emergency room, The best thing we could do is just increase the amount of oxygen availability to you. So you give them a mask of oxygen. I can't give you a medication that causes it to go from the lungs into the blood any faster, because we rely on diffusion. And that's because diffusion is passive. There's nothing we could do about it. Now, very quickly, when the oxygen enters into the blood, it will very quickly cause the oxygen levels in the blood to get up to about 100. So now I've oxygenated the blood, and then the heart pumps that to the tissues. And this now takes us to internal respiration. The oxygen levels in our body cells are generally going to be around 40. But the blood coming in the arteries, that's going to be about 100. So I've got 100 oxygen molecules in the blood, 40 in the cells, and very quickly oxygen will leave the red blood cells and enter into the tissue. And that's what we want. What's explaining carbon dioxide is the same thing. It's Dalton's law. We have what are called these partial pressures, so the carbon dioxide will follow its concentration or its pressure gradient, and it goes from the cells into the blood, and then to the lungs, from the blood into the lungs, and then out. What explains this movement is Dalton's law of partial pressures. So we went over the mechanics of pulmonary ventilation. What explained that was Boyle's law, and how we accomplished that through increasing the size of the chest. But that was just mechanically moving the gases in and out. Here we have to basically rely on the chemical aspect of the gas to move itself. Because all we're doing is just asking the oxygen, carbon dioxide, we'll transport you, but you're going to have to move on your own once we get you there. Like the taxi guy. I'll drive you to the airport, but you're going to have to walk on the plane. I'm not going to carry that. That ain't part of the freaking job. Same thing here. We'll get you into the lungs, but you have to go from the lungs into the blood, and that's the gas's job to do it. So what explains that chemically is Dalton's law of the pressures. It's the actual inherent movement of the gas itself. Correct.
I was showing the oxygenated blood having 40 units of carbon dioxide, and there's 45 in the tissues. Is that accurate, or would there be no carbon dioxide initially when you oxygenate the blood?
Oh no, there'll still be carbon dioxide in there. It's never
So
complete.
that's not diffusing as fast as the oxygen then?
Oh,
You're not
it
removing-
diffuses, carbon dioxide diffuses 20 times faster.
Now, how is that if the units are so close together? According to that diagram anyway, it's showing it's 40, and then down here it's 45.
Yeah, it's 45. Carbon dioxide has a much easier movement than oxygen does. That's why we have to keep oxygen at such high levels. You need that high pressure gradient to force it along. Carbon dioxide moves much easier. So it moves 20 times faster, so I don't need, it gets into the
You
chemical
don't need that
makeup.
high of a gradient.
You don't need that high of a gradient. You don't need that high of a gradient. Yeah, and we have to work to keep that balance. So we have to kind of balance out how much oxygen we use and how much CO2 we produce. But that's what cellular respiration does. If you disrupt these percentage balances, then you wind up having problems. Okay? All right, so this explains how we get internal and external respiration to occur. The next thing we want to take a look at is how do we transport these gases through the blood? We saw how we can exchange, but now we want to see how we transport them through the blood. Now we take a look at, well, we're looking at chemistry a little bit more. What determines how we transport oxygen and carbon dioxide through the blood is the concept or the phenomenon that those of you that had chemistry looked at. It's called solubility. The thing that determines how we transport is solubility. Because if I want to transport something in the blood, it has to dissolve into its liquid component. It has to dissolve into the plasma. If it can't dissolve, you might be able to transport it, but you're not going to be able to transport it sufficiently. So when we take a look at these two gases, we'll look at oxygen first. Oxygen, not very soluble in water. It's soluble, but not very soluble. Now you could play around with the solubility by playing around with the pressure. You can increase solubility of a gas in a fluid by increasing the pressure. Anybody know whose law that is? Chemistry affects schematics. When you have, let's say you're parched, and you say, yeah, I need a beverage. I need a cool beverage. Well, do you want juice? No, I don't want juice. I don't want the juice. I want something with a little sparkle. A little sparkle to it. I think I want a pop. Well, what makes the sparkle in the pop?
Carbonation.
It's called soda in the other parts of the world. Out here we call it pop. It's called soda. When the company that makes it calls it soda, it's soda.
When it makes a popping noise.
Yeah, I know, because I can't spell soda. Soda. All right, what's in the pop that gives it the little spark? Bubbles. It's a gas. So what they have done, if you've ever seen a bottling company, they will infuse carbon dioxide. That's why it's called carbonated. They will infuse carbon dioxide into that. But carbon dioxide isn't very soluble in the pop. So what they have to do is that they have to increase the pressure to force that quantity of carbon dioxide to dissolve in the pop. And the reason why when you take the top off the pop, the bubbles start wanting to come to the top of the pop is because when you take the, you're starting to equalize the pressure, so now the gas is coming out. It's all based on solubility. That's called Henry's Law. Hanks' Law. I'm not going to ask you that, but that's what it's called. It's in the freaking book. Anybody scuba dive? Do you have to know Henry's Law?
You have to know Boyle's law.
And you have to know Hank's. Because Hank determines how much nitrogen dissolves in your blood depending on the depth that you go. When you're scuba diving around, your self-contained underwater breathing apparatus, that's scuba. We need to know that. Now, you guys are probably going to have to know this because they have these things. Did anyone ever hear of hyperbaric oxygen treatments?
Mm-hmm.
Basically, they put you in this tube with a high pressure of oxygen and just diffuse it into your freaking tissues. And that can kill you, but it's kind of cool to watch. They do it for people with chronic ulcers, surface ulcers, that don't have very good circulation, so they force the oxygen in that way. Do they have any around here? I know Cleveland Clinic was looking at it.
Akron General got one.
Who?
Akron General.
Akron General. And they use it on burn patients up there. Because burns, you know, when you burn the capillaries in the tissue, because they got down to the 3rd degree, How are you gonna get oxygen there? You can't. So what they have to do is push the oxygen into the tissue, and that's relying on solubility. So when you're doing the scuba thing, ding, 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 ding. You got the little anchor there. All right, got the little fishes with the shark things. Okay, so we're all Australia. Now you can go swimming around under the water up here, with your little goggles on, and it's not a problem. But then all of a sudden you want to go hanging out down here where all the rocks, and they got some big freaking clam down here that's looking up at you, and it's saying, if you swim down here, I swear to freaking God, I'm gonna rip your freaking arms out. So now you're hanging out down here. Because of all this weight of basically the entire ocean that you're in, okay, that's going to cause the nitrogen in your lungs to dissolve into the blood. And that can become problematic because if you're down here and you have to go up, then it's going to start to come out. And if it comes out too quickly, like the soda can, it's going to create bubbles. And now you have gas emboli going through your bloodstream. Anybody know what that's called? Not the straights, the bends. Get it? Bends in the straights.
If you do it fast enough from a high enough pressure to a really low pressure, it's explosive nitrogen expulsion.
Yep, because it just comes out way too quick. So it's going to bubble in the blood. That's what will happen. So you have to ascend at a certain rate. That's why they have to have watches and timers. So they have to decompress. If not, then you have to go to a decompression chamber, which there's not one on that boat. There's not one on that boat. So they would have to go up very slowly. What that is, it's the nitrogen that dissolves in the blood. Anybody know what a caisson is? It's a job. That's good, but no. If, let's say, I don't want to go in the boat. I want to drive. I want to drive over to here. I want to go over the water. So I have to build a bridge. So I'm going to have to put some poles into the water real deep on the floor to support that bridge. How are they going to get cement down there?
Ask the mafia.
Well, that's getting it to the site. They're getting it down here. There were specialists that used to put they were called caissons. They would basically pour the foundation for the bridge. The way they did it was, in the old days, what they would do is that they would build a dome under the water. And then what they would do is, through air pressure, push air in here, which would then force the water out, so you can work under that. But how high does that pressure have to be to keep the water from coming back in? What?
Higher than the water.
Oh yeah, because that water is just going to go up, and it says, I didn't go anywhere, it's still here, and it's going to want to come back under. So these guys are working under high pressure. And they used to get what's called caisson's disease. If they ascended too quickly, the nitrogen would come out of their blood, their eyes would rupture, they would have strokes. So what they used to have to do, they used to have stairs. They would walk up a certain level and they'd have to sit there on the stairs for a while. And then they go to another level, sit there for a while. Go there for another level. Or they would sit in an elevator, boom, stop, boom, stop. Does that make sense? Because of the high pressure. They were causing more nitrogen to dissolve in their blood. It's called caisson's disease. And what that high pressure does, it dissolves more gases into the blood, which can be problematic for us. So everything we do to get gases into the blood itself, relies on the concept of solubility. Once we get it in there, we can then attach it to something and deal with it. Any questions? All right, we'll take a look at that on Thursday.